You good to go?
So, good afternoon, everybody, and welcome to today's presentation. This is our fourth in the pancreas series. And again, to just say that Gecko is hosted by the Gastro Foundation in association with Project Echo, University of New Mexico. And these sessions are held weekly on a Wednesday, and the chat is open for questions. We'd just like to thank Professor Cassanides for his input into this and bringing pancreas into these sessions together with Dr. Bobat. So it gives me great pleasure to introduce Dr. Madela. He's the academic head of GIT and UKZN and works at Nkosi Albert Lutuli Hospital. It's really wonderful to see him grow up over the years, and I'm really looking forward to his talk on chronic pancreatitis. So, Dr. Madela, all yours.
Can you see my slides, John?
Yep, we can see them.
All right. Good afternoon, everyone. First of all, as a way of disclaimer, I'm a surgeon, and I appreciate that this topic is one that is managed by a multidisciplinary team, and there's many approaches that involve in the management, in particular of patients with chronic pancreatitis. And naturally, as a surgeon, you'll find that my talk has a heavy bias towards surgery. But hopefully, at the end of this, I'll still have friends in gastroenterology. So the topic for this afternoon is on chronic pancreatitis and malignancy. And the question is, where are we now? And I wonder if we have moved at all, but hopefully at the end of this talk, we'll be able to answer that question. Oof. Eh, for some reason, now my slides are not progressing as they did earlier. Okay, you can see my slides still?
Yes, we
Yes, we
can.
can.
Yeah. So, as a way of introduction, chronic pancreatitis is a progressive inflammatory disease of the pancreas, which presents with chronic pain, loss of endocrine, as well as exocrine function. The classical triad of histopathological features include your parenchymal fibrosis, acinar atrophy, as well as ductal abnormalities. Now, antecedent chronic pancreatitis is a risk factor for pancreatic ductal adenocarcinoma. But at the same time, you can develop chronic pancreatitis as a result of pancreatic cancer, and this is due to tumor-related ductal obstruction. And 5% of pancreatic cancers are misdiagnosed as chronic pancreatitis and vice versa. Now, I've a misdiagnosis of chronic pancreatitis as pancreatic cancer is accompanied by high morbidity resulting from inappropriate management, as well as and a misdiagnosis of pancreatic cancer is accompanied by mortality due to the delay in management. So, to start us off for this afternoon, I've got two case vignettes just to illustrate the point that I've just made. The first patient is a 44-year-old man who has a background of alcohol-induced chronic pancreatitis and was treated as such for a few months before presenting to our unit with obstructive jaundice that was complicated with cholangitis. And at that stage, he required preoperative biliary drainage because at that stage, the bilirubin was in excess of 500. He had a low albumin, and the septic markers were suggestive of cholangitis. We booked him for an ERCP, and as you can see on the image to your right, he had a long biliary stricture with an abrupt cut off. We proceeded to perform an EUS in light of the abrupt cut off as well as the long stricture. And on EUS, there was an indeterminate periampullary mass. We decided on the basis of those findings to proceed to a Whipple's procedure. And subsequent to the surgery, the histology report confirmed that he had a background of chronic pancreatitis, and the findings were in keeping with invasive adenocarcinoma. To be more specific, they found a pancreatic intraductal tubular neoplasm, which was associated with invasive adenocarcinoma. Fortunately, in this case, there was no difficulty with making that assessment because there was perineural as well as lymphovascular invasion. He did well, and he is currently having his adjuvant therapy. Our second patient is a 74-year-old lady who was also known with chronic pancreatitis, but we never got to establish what was the cause of her chronic pancreatitis. When she presented to us, she was a frail lady who had a recent loss of weight, and this was despite the fact that she was on adequate replacement therapy for pancreatic insufficiency. We proceeded to a CT scan, which also found an indeterminate head of pancreas mass. Following the CT scan, we proceeded to an endoscopic ultrasound, and on both occasions, the samples were representative, but the histopathological findings were equivocal. We then decided, because of her performance status and her frail condition, to proceed with surgery for chronic pancreatitis. And intra-op, we performed a biopsy. And as you can see from the frozen section, they basically gave us equivocal findings. And this was now the third or fourth biopsy result. And in this case, they indicated that the histology favored invasive adenocarcinoma. However, in their differential, they also thought it could still be chronic pancreatitis with reactive atypia. So as you can imagine, this was a little bit of a challenge considering the patient to decide how to proceed with this patient. And this leads me to our topic for this afternoon. And for starters, I'm going to talk about the epidemiology of chronic pancreatitis and pancreatic cancer. As you can imagine, chronic pancreatitis is a significant proportion of the risk factors for pancreatic cancer. It's not the biggest risk factor, but it's a significant one. And you will see that I've separated chronic pancreatitis from hereditary pancreatitis. And in this pie chart, chronic pancreatitis has an up to 60-fold risk of developing pancreatitis or pancreatic cancer. And hereditary pancreatitis has up to 87 times risk of developing pancreatic cancer. And the lion's share of this risk is found in patients with Peutz-Jeghers. Now, if you look at the histopathological specimens following surgery for pancreatic cancer, in a study in Helsinki University Hospital, they found that up to 39% of specimens had chronic pancreatitis. And this was generically for everyone undergoing surgery for pancreatic cancer. In our local study, if you look at the subset of uh, patients undergoing surgery for pancreatic ductal adenocarcinoma, that percentage is even higher. We found it to be up to 55%. Now, the incidence of pancreatic cancer in chronic pancreatitis cohorts is reported to be between 5 to 7%, with one study reporting it as 6.6%. And in this cohort of chronic pancreatitis, the most important risk factors for progression to pancreatic cancer are your older age at onset of chronic pancreatitis, as well as smoking, which has been reported to double the risk of developing pancreatic cancer. So the chronic pancreatitis incidence globally is reported to be between 5 to 12 per 100,000 person years. And in that cohort, pancreatic ductal adenocarcinoma affects 5 to 7%, as reported earlier. So for our talk this afternoon, we're also going to look at the pathophysiology of progression of chronic pancreatitis to pancreatic cancer. And I'm aware that it's a very exhaustive topic. And so for this afternoon, I've chosen to focus on chronic pancreatitis with ductal ectasia, and in particular, how those patients progress to pancreatic cancer. In terms of pancreatic carcinogenesis, germ cell line mutations within the hereditary pancreatitis genes are not necessarily directly associated with progression to pancreatic cancer, contrary to what was previously believed. However, it's been found that it's the inflammation itself and not the hereditary pancreatitis genes that promote pancreatic cancer. And it's been reported then that there's two signaling pathways that lead to progression to pancreatic cancer, and I'll go into those briefly. To further make a point for this, there's a study by Malats et al. That found that the incidence of mutations of the CFTR gene in sporadic pancreatic cancer is actually similar to that in healthy controls, right? And then the other component that has led the other observation that has led to this assertion that it's mainly the inflammation itself that promotes pancreatic cancer is that stromal cells constitute 90% of the total tumor mass, and this is contrasted with only 10% of malignant cells. So the two signaling pathways for progression to pancreatic cancer are divided into extrinsic as well as intrinsic pathway. The extrinsic pathway is essentially your inflammatory stroma, where you find leukocyte within the tumor stroma, as well as cytokines and growth factors, which play a key role in the tumor formation. And the second pathway is the so-called intrinsic pathway. And in this pathway, they've observed that pancreatic cancer takes up to 20 years to grow into a detectable tumor. And during this time course, there's an average of 63 genetic mutations, and or rather genetic alteration and point mutations. So, and with these mutations were not necessarily referring to the hereditary pancreatitis mutations. So if you look in the inflammatory signaling pathway in particular, you find that you develop ductal ectasia. And contrary to what was previously thought, people thought that ductal ectasia is as a result of the ductal lining of of the pancreatic duct. However, in this observation, they found that what you have is acina to ductal metaplasia. So your pancreatic acina undergo a type of metaplasia. And then if there's an insufficiency of autophagy of the KRAS mutations in this metaplasia, these patients go on to then develop pancreatic intraepithelial neoplasia. And this goes all the way up to your higher grades. And then from there, you develop a pancreatic ductal adenocarcinoma. Now, pancreatic intraepithelial neoplasia is one of the most common precursor lesions in pancreatic cancer. However, it's also found in 16% of healthy adults, as well as 60% of patients with chronic pancreatitis. What the observation is that only 1% of these precursor lesions will eventually lead to a malignant transformation. And the reason they end up leading to malignant transformation, as indicated earlier, is that if you have insufficient autophagy, particularly in chronic pancreatitis, these KRAS mutated pancreatic epithelial cells will eventually develop into pancreatic intraepithelial neoplasia. And their accumulation is prevented further by the malignant progression. Hence, you have a low, or rather, this autophagy is inhibited by your P3, and as a result, you have a low transformation to invasive pancreatic ductal adenocarcinoma. So your acinoductal metaplasia and loss of tumor suppressor barriers predisposes to subsequent progression to intraepithelial neoplasia. So now the question is, in this cohort of patients with chronic pancreatitis, who needs surveillance? Unfortunately, there aren't many guidelines or recommendations for surveillance. I found the American Gastroenterology Association recommendation was specifically just for your PRSS1, or rather the cationic trypsinogen hereditary pancreatitis. And these patients, according to their recommendation, they need to be screened from the age of 40 every 12 months. And the modality that they recommend for screening there is MRI as well as endoscopic ultrasound. The rest of the mutations, like your SPINK1, CFTR, CTRC, CPA1, were found not to have a high enough risk of pancreatic cancer to justify screening or surveillance. And other guidelines from other international pancreas associations do not recommend endoscopic ultrasound for screening in patients with chronic pancreatitis. And this is due to difficulty identifying early pancreatic cancer on endoscopic ultrasound. However, they recommend CT scan instead. Now, one of the biggest challenges with management of chronic pancreatitis and pancreatic cancer is the issue of diagnostic differentiation. And generally, we tend to have a triple assessment with these lesions. And if you start with biomarkers, one of the most widely used tumor marker for pancreatic cancer is CA19.9 with a reported sensitivity of 80%. However, in chronic pancreatitis, it's been found that these patients are highly expressive of CA19.9. So in that cohort, you're bound to have a high false positive. And the second problem is that often in normal or rather, CA19.9 is often normal in high-risk patients, like your patients with higher grades of pancreatic intraepithelial neoplasia, as well as patients who are harboring IPMN. The second challenge with regards to diagnostic differentiation has to do with imaging. A lot of the imaging modalities have a low sensitivity and specificity for differentiation of chronic pancreatitis as well as pancreatic cancer. However, endoscopic ultrasound-guided FNAB has a relatively high diagnostic accuracy compared to FNA, particularly for differentiating your pseudotumor pancreatitis from pancreatic cancer. And if you combine CT scan with MRI, particularly looking for high risk features for pancreatic cancer, it's been found that combining both of them improves sensitivity and specificity, and particularly if you use the CT combined with diffusion weighted MRI as well as MRCP, particularly in patients with a mass-forming pancreatitis. The third challenge with diagnostic differentiation has to do with histopathology. Chronic pancreatitis as well as pancreatic cancer share overlapping histologic features. However, histology still remains the cornerstone of the assessment despite these limitations. The histopathological features of chronic pancreatitis include dense fibrosis with variable inflammation, preservation of lobular architecture, although it may be distorted. You have ductal changes with ductal epithelial hyperplasia, ductal ectasia, and squamous metaplasia. You also have presence of reactive atypia without overt malignancy, as well as periductal and interlobular fibrosis, which tend to predominate. And the histopathological features of pancreatic adenocarcinoma include infiltrative glands with irregular shapes and sizes. You get marked cytological atypia in the form of nuclear pleomorphism, as well as a prominent nucleoli. You have desmoplastic stromal reaction, which can mimic fibrosis in chronic pancreatitis. You also have loss of lobular architecture, and you may have perineural and vascular invasion, which makes the assessment a little bit easier. Now, the main challenges then in histology include the following. In patients that have reactive atypia versus malignancy, so you have reactive changes in chronic pancreatic ducts that may mimic carcinoma, particularly when you do an FNA cytology. And then with regards to the fibrosis overlap, as mentioned earlier, you get a desmoplastic reaction in pancreatic cancer, which also resembles chronic pancreatitis fibrosis. And then the third issue has to do with sampling limitations, where small biopsies may not capture the invasive areas. The fourth challenge is relating to the inflammation itself, in the sense that you get dense inflammation, which could obscure tumor cells. And the last issue has to do with architectural distortions. As indicated in both conditions, you get disruption of normal pancreatic architecture. So there's a number of strategies that the pathologists employ to try and overcome this challenge, and they have to do with the use of immunohistochemistry, molecular testing, and also encouraging clinicians to sample patients adequately. With regards to when you should suspect pancreatic cancer and chronic pancreatitis, clinically, if you start, if your patient starts developing obstructive jaundice, you should have a high index of suspicion that they may have progressed to pancreatic cancer. And also patients that have a markedly dilated pancreatic duct, particularly if it's worsening, those patients are a little bit of a concern. And as with our index patients, patients that have an unexplained weight loss despite pancreatic enzyme therapy, it is suggestive of an alternative pathway to their weight loss as opposed to chronic pancreatitis itself. And then also patients that have a markedly elevated CA19.9, it should ring alarm bells for a possible source of pancreatic cancer, although we've indicated CA19.9 per se is not necessarily diagnostic of pancreatic cancer in this cohort of patients. And then on your MRI and CT, we should look for high-risk features for pancreatic cancer, which include a hypovascular lesion, a smooth upstream pancreatic duct dilatation, distal atrophy of the pancreatic glands, lymphadenopathy, as well as vascular invasion. Now, as I indicated, the management of these patients still represents a challenge, which in 1968, after this publication in the Annals of Surgery by William McCune, almost like got a lot of people excited that there was a beginning of a renaissance of management of these patients, particularly with endotherapy. Subsequent to that, people looked into the multidisciplinary step-up approach. The reason we still continued with the multidisciplinary approach was mainly because the optimal management of chronic pancreatitis remains a subject of debate. There's many different practices in terms of how these patients are managed, and there's multiple management algorithms in terms of management of these patients, particularly if you start including your autoimmune pancreatitis and hereditary pancreatitis, or patients with pancreatitis without ductal ectasia. The algorithms are innumerous. So this approach, step-up approach, was punted as the solution to this challenge. And the first step included conservative management with lifestyle management like smoking cessation, dietary changes, and pain management. The second step included endotherapy. with the primary focus being to deal with pancreatic duct strictures as well as stones. And the last tier to this step-up approach was supposed to be drainage as well as resection. However, this approach does not find much support in terms of research in terms of this approach, in terms of management. There was a randomized controlled trial that looked at the management, endoscopic management, as well as versus surgical drainage of pancreatic duct in patients with chronic pancreatitis. The problem with this randomized control trial was that one, it was a small size, and they excluded patients with an inflammatory mass. However, their main findings was that patients that undergo surgery for chronic pancreatitis have a long-lasting superiority of pain relief, and also that they have a better quality of life. And in a small subsection of these patients, they found that endotherapy has benefit. And that subsection was patients who had stones or strictures that were confined in the head of pancreas and where complete ductal clearance was achieved. Subsequent to, or rather, before we get to that, in the very same study, the main finding was that when they looked at the Izebiki pain scores, there's a clear separation between patients that had endotherapy versus patients that underwent surgery for chronic pancreatitis. And this led to a subsequent study that looked at the same things, basically your early surgery versus endotherapy in patients with chronic pancreatitis. With this study, the sample was bigger. They had 86 patients, as well as a longer follow-up of 8 years. The main findings were not dissimilar to the previous study. They found that early surgery was superior to an endotherapy first approach. But in addition to that, they found that patients that started first with endoscopic intervention and then progressed to surgery had better, or rather had worse outcomes compared to patients that underwent early surgery. And the third finding was that, contrary to the previous study, obtaining endoscopic ductal clearance did not improve outcomes. So we have from the United European Gastroenterology a number of recommendations in terms of the management of patients with chronic pancreatitis. And I've picked a few, and as I indicated again, the bias was heavily slanted towards surgery. There were other recommendations that had to do with endotherapy. But the main recommendation is that surgical treatment or endotherapy have no role in asymptomatic and uncomplicated chronic pancreatitis. But they also recommend that surgery is superior to endotherapy in terms of pain relief, and that early surgery is favored over surgery at a more advanced stage of the disease in terms of optimal long-term pain relief. In terms of the surgical options, they recommend that for patients with dilated pancreatic duct with normal-sized pancreatic head, a procedure like a Partington's Rochelle or a Frey's procedure will suffice. And they also find that there is no difference in terms of long-term outcomes between the many iterations of duodenum sparing resections of the head of pancreas. In patients with groove pancreatitis, the initial therapy there they recommended should be medical treatment, and they also recommend that endotherapy may be helpful. And ultimately, if all these attempts fail, for the patient to be referred for surgery. Now, in terms of the benefit for surgical therapy, I've chosen two papers recently. The one was from 2013, and the more recent one was from 2019. And one is from China, where they looked at 506 patients who were analyzed retrospectively. Now, in this study, they excluded patients that were diagnosed with pancreatic cancer in the first 2 years during the follow-up. And that was mainly because, as I indicated earlier on, we need to separate between antecedent chronic pancreatitis from post-sident chronic pancreatitis, because post-sident chronic pancreatitis is as a result of pancreatic cancer, and as such is not necessarily a risk factor or a cause for pancreatic cancer. The diagnosis in this study for chronic pancreatitis was based on a predetermined Japanese Pancreatic Society criterion. In this study, they found that the cumulative incidence of pancreatic cancer was higher for patients that did not undergo surgery, and it was lower in patients that undergo surgery for chronic pancreatitis. And then subsequent to that, in 2019, there was a Chinese study which looked at, again, more or less the same thing, the risk of pancreatic cancer in patients who have undergone surgery for chronic pancreatitis. In this study, it was a retrospective analysis of a prospectively collected database, and they included 650 patients with histopathologically confirmed chronic pancreatitis over 9 years. In this study, they excluded autoimmune pancreatitis, as well as those patients that had total pancreatectomy. And the main finding in this study was that time interval to surgery, as well as de novo endocrine insufficiency, were the main risk factors for development of pancreatic cancer. In other words, early surgery played a protective role against development of pancreatic cancer. Now, the other component that we need to look at briefly with regards to chronic pancreatitis is that it's a prognosticator, particularly in patients with pancreatic cancer or patients who undergo surgery for pancreatic cancer. And this is based on the Helsinki University Hospital study that found that disease-specific survival following surgery for pancreatic cancer is shorter than, or rather is shorter in patients with post-sident chronic pancreatitis than patients without chronic pancreatitis. And the mechanism there of poorer prognosis is thought to be due to a pro-inflammatory state like the one in the Japanese study, where they found that pancreatic cancer patients with high CRP to albumin ratio had a significantly worse overall survival, as well as disease-specific survival than those with a low ratio. And this was further confirmed in a systematic review, even though it was only of 10 papers in Europe, that found that CRP and a modified Glasgow prognostic score, as well as neutrophil lymphocyte ratio in pancreatic cancer, are inversely proportional to survival. So, in conclusion, chronic pancreatitis is a significant risk factor for pancreatic cancer, but it is also a prognosticator of pancreatic ductal adenocarcinoma. There are many challenges with regards to diagnostic differentiation between the two conditions, and this is despite your triple therapy of using biomarkers, imaging, as well as histopathology. And there's a lot of development and research with newer approaches like liquid biopsy as well as your cDNA. However, many of these newer biomarkers have not yet undergone validation. And lastly, early surgery in symptomatic chronic pancreatitis has a protective role against pancreatic cancer. I welcome any comments. I recognize that this topic is fairly controversial and that there's a lot of different management algorithms out there. And I know my gastroenterology friends would differ with me on a lot of points. Thank you.
No, Fusi, I think thank you for putting that together. And I think it's an extremely difficult topic to deal with. And I do think that we haven't found the answers to this. And I think that when you look at it, there's no specific imaging that really makes a massive difference, and not in the kind of patients that we see. I think the kind of patients we see with that, sort of stones in the duct and the significant calcification all the way through the gland makes it a nightmare for us to deal with because the parenchyma is pretty much gone. And if you have an acute exacerbation of your chronic pancreatitis and an inflammatory component, makes it even more challenging. So one of my questions to you is if you look at it is how the use of endoscopic ultrasound for me has been like a real game changer in pancreatic disease. But has it really in the realm of chronic pancreatitis, with particularly chronic calcific pancreatitis? Because those stones cast shadows everywhere.
Yeah.
So maybe just give us your opinion on sort of your diagnostic workup
Yeah,
for these
yeah, yeah.
patients.
I think, like you indicated, it's a challenge because also besides the calcific changes as well as your the shadowing that you get from calcifications, you also have a loss to the architecture of the pancreas. So you have multiple hypodense areas mixed with hyperdense areas. So even with endoscopic ultrasound, it's very difficult to have an area that you can target for sampling. And a heavy reliance on endoscopic ultrasound in this cohort of patients may lead to a delay in intervention because you've targeted a specific area. And I think that's why you find that the other two, or rather, the American Gastroenterology Association tends to go with MRI with EUS as opposed to EUS on its own. There's been recommendations of contrast enhanced EUS, but it's mainly useful for your autoimmune pancreatitis as opposed to your common chronic pancreatitis. So I know that I'm not giving you any answers, but it's still challenging.
So just in terms of this, the last article that you put up, in terms of when to go for surgery, you spoke about a 9-year mark. there that people were looking at in that last article. But what is your approach here, and what is your recommendation? Early surgery, wait and watch approach. How do you stratify your patients and how do you manage these?
So I think in our practice, we adopted this approach very early on of early surgery. So generally, for patients that are symptomatic with ductal ataxia, we do not hesitate, having obviously optimized their conservative management with lifestyle modification as well as pain control. We do not delay intervention like with surgery for chronic pancreatitis. So we tend to we don't do as much and endotherapy as maybe other units may do. And again, I think discussing around the country, I encountered that other units, for example, do the same, but they've sort of like come up with a hybrid where at the setting where you're doing surgery for chronic pancreatitis, you then get a more representative tissue sample. But my question in that instance has been, particularly with the delays with pathology, what do you do if a week later your sample comes back confirming neoplasia and also the challenges that you're going to experience with going back? So it's a very difficult one, but we generally tend to go with early surgery, particularly if they're symptomatic.
Yeah, no, fantastic. I see Dr. Burmeister is on, and I'm just going to use the chair's prerogative. If Dr. Burmeister can hear us, it would be really hi, Sean. I can see you there.
Hi.
Hi, really nice to see you on this platform, and maybe you can just give us an opinion about how you work your patients up with chronic pancreatitis from Cape Town, and when you're considering malignancy, and just in general your approach.
Yeah, John, thank you very much for the opportunity. I think first of all, I'd just really like to congratulate Fusi. I mean, this is a very difficult topic. I mean, this is a topic for a whole conference, and I think Fusi's really covered sort of the topical and important points. And to be fair, I think for a lot of the issues that you've addressed, there actually aren't clear answers. So it really is a difficult topic, and Fusi, I think you've done a great job. So thanks very much for that.
Thank
I
you.
think, yeah, if I may, I'd like to make a couple of comments that I think just point perhaps not even points of departure, but even points of emphasis. And I just really I want to reiterate that the situation where you have a patient with clearly well-established chronic pancreatitis, as you said, with often with calcifications and all the changes that are listed in the Rosemount criteria, and differentiating whether there is a cancer lurking within a patient with those kind of features, I think is virtually impossible. When you're identifying a pancreas in an otherwise normal when you're identifying a carcinoma in an otherwise normal pancreas, you rely on the fact that the adjacent tissue is different. And when the whole gland is diseased, I must say, I find it extremely difficult. And so I think what is really important is that when we diagnose these patients, I mean, one has to decide if there's an indication for a oncological approach up front and whether that's directed. But invariably, these patients end up being surveilled by us, and you watch them over a period of time. And what I think is really important is that what you've got to be looking for is change. Change in the patient's pain control, change in the patient's endocrine or exocrine function, change in the tumor markers, change in morphological appearance on serial imaging. I think all of those come together in terms of trying to pick up patients who develop a malignancy. And having said that, I certainly, our anecdotal experience is similar to what Fusi has described. I think when these patients get a cancer, it's often a very aggressive cancer. And we've had patients in our cohort who we've been watching like a hawk, they've had a scan 6 months prior to presenting with metastatic disease that was exactly the same as what it had been for a number of years. Nothing had really, and simply in the 6 months that we haven't seen them, there's been a dramatic change and the development of a rapidly aggressive cancer. And I don't really know how one avoids that. But nevertheless, I think surveillance is key. I think when you are surveilling these patients, you need to be watching each of the components of chronic pancreatitis disease, being pain, endocrine and exocrine function, and malignant threshold. You need to be watching those carefully. And quite often it's the trend that alerts you rather than anything else. Two other things I just wanted to mention. I'm not sure if I missed it. I did miss the first few minutes, but I think genetics is also something that we need to be cognizant of. And I think in particular, be careful with the patient who presents with no clear risk factors. And unfortunately, the patient who takes an odd glass of wine often gets unfortunately labeled when they present with chronic pancreatitis. And we've had many patients who only come to us late because it's been assumed that alcohol was the cause when actually there are other factors at play. So I think one has to be cautious about, obviously alcohol and smoking represent the commonest risk factors, but be aware that there are other things that may be at play, and in particular genetics. So be cautious if your patient's alcohol intake is in fact doesn't fit the typical role. And genetics, I think, can play a really important role, especially if you are going to be undertaking surgery in terms of what surgery you're going to be undertaking. Because if your patient has a genetic mutation that places them at risk for malignancy, well, then performing a drainage or hybrid procedure may not be what's appropriate. So I think the genetic aspect is something that needs to be kept in mind. And then lastly, I think just kind of a word of caution or a word of warning, if you will. Always be on the lookout for IgG4 disease. We've seen, I mean, this year alone, I think we've seen 3 or 4 patients who really presented with sometimes bizarre appearances. But, in our series, we've got a series of about 25 patients now, and virtually none of them has presented exactly the same. So, and they can present with masses, they can present with isolated pancreatic ductal strictures, isolated biliary strictures, or any combination of the above, and even some things which I haven't mentioned. But in the right setting, especially in the absence of calcific disease, beware of occult IgG4 disease. Thanks, John. I think I've taken up quite a bit of time. I'm not sure if there are any other specific questions that you wanted to ask, but I thought that those were maybe just additional things that I could add.
No, I think that's fantastic. I think one of the exciting things that might come through is looking at circulating biomarkers, but the circulating biomarkers might be slightly different and maybe even circulating free tumor DNA. And I think that that might be a place that we can look at with chronic pancreatitis because there's so much inflammation. And one of the things to do would be to probably look at what's circulating peripherally in those with standard chronic pancreatitis and that those that actually have malignancies and see if we can pick up anything in between there. And I think that might be kind of the holy grail and maybe even at the tissue environment looking at that. But we far off from that, and that's all investigational, as you say. I really love the points about change and everything that you've introduced. So thank you very much for those eloquent comments. Um, Fusi, I'm not sure if you'd like to respond or if there's anything else you'd like to add around this, but please go
No,
ahead.
no, I think Prof. Burmeister made very important comments, and I think in particular with the genetic mutation, the only thing there to add is that your hereditary pancreatitis with genetic mutations per se do not necessarily cause pancreatic cancer, or rather, that's the controversy, and it's mainly because of their excessive inflammation that you end up getting with the progression to pancreatic cancer. So I think it's important to look out for that subset of patients, particularly when you're managing patients with chronic pancreatitis with high-risk features. And I think, as Sean indicated, to inform the surgical option that you end up adopting.
Yeah, no, absolutely. I think with that, I think we should look at probably calling the session close unless there's any other questions. I don't see any other questions in the chat. So just Fusi, thank you so much for taking the time to put this together. And it's once again just to thank everybody for being here on the platform. Thank you for the comments that have gone through. And just to note that project, thanks to this to iEcho and UNM and the University of New Mexico and the iEcho India team. Recordings are available on the Gastro Foundation website, and thanks to the Gastro Foundation. And once again, thanks to the sponsors. But most of all, thanks to the delegates that have come through. We've had a fantastic turnout. Please continue to keep coming through. It was really lovely having you here. And once again, thanks to Professor Cassanides.
Thank you. Excellent. Thanks, guys. Thanks, Fusi. Excellent talk.
Thank you. Thank you.